I think all of us would agree. I mean, all of us have been in this field now a very long time. There's no question we have better medicines now than we did 10 or 20 years ago. Really, they're better medicines. They last longer. You don't have to take them as often. But it is distressing that in the last 20 years, there's only been one drug of a new class that's been introduced.
Absolutely.
And that has to change if we move forward. If you look at what's happened in the cardiac world, where they've got 15,000 different classes of drugs that they're using, we need to move that forward. So we're better, we can make a difference with what we have, but we need to do better.
Well, let me ask what sounds like a trivial question, but I'll bet it's not. What are the actual goals? What do you try to achieve in goals of therapy here?
Well, I mean, I'll speak from my own personal experience in dealing with family members. If you speak to patients, they're clearly interested in an improvement in their symptoms and their quality of life. I mean, that this is a disorder that does impact, as for reasons that Frank has said, multiple components of the patient. And as we've talked about, Peter, the decreasing exercise tolerance over time, the complexity of that combination, is associated with significant symptoms, breathlessness, and exercise limitation. Patients want that to be improved. And so in all of the therapeutic algorithms that we have, with the new drugs, as both of these young men have pointed out, incorporated in various components. You started doing this when you were 5 years old.
I didn't miss the young
Byron,
man
so that's
comment
what I'm pointing out there. And so that component is a key component. And patients, that's the key thing that they see every day when they're limiting their activities, as Frank pointed out. Then there's been an evolving thought, which has been 20 years in the making. Jim, you've contributed a lot of this in some of the studies you've done, that there are acute events, these flares of disease, exacerbations, bronchitis, whatever you want to call it, depending on which part of the country, there are different terms to how that's described. And it's now become very clear that those events, not only are patients scared of them, and it really has a dramatic effect on their quality of life, which may take months to resolve if it ever completely resolves. But those events are associated with multiple markers of the progressive components that Frank describes. They're associated with changes in future health status, functional capacity, potentially even worsening of lung function, structural abnormalities. A lot of things have been linked to those acute events. So if you think about the paradigms now, the paradigms are try to prevent, multiple components and approaches to that, treat the symptoms and exercise tolerance, and try to get the patient active, as you said, Peter, get up and walking around, and then try to prevent these acute events. That's really sort of the key combinations now.
So if I can just simplify what Fernando said, we've always just treated, comprehensively, it's important.
Pretty simple to me, but...
Frank's always good at making things very palatable.
Palatable.
One sentence, okay. Not only do we treat the symptoms and your patient says they feel better, but we adopt the philosophy that the cardiologists have taken for years with antihypertensives and statins, is that the drug, even if immediately it doesn't have an impact on how you feel, can prevent serious events down the line, flare-ups and even death potentially.
Let me ask two very brief questions, if I might, because I heard you talk once. I did listen. And
Unlikely.
I did, because what Byron says is usually very smart. You pointed out that some of these long-acting drugs, if they continually dilate your bronchioles, will eventually result in decreased lung volume, increased lung efficiency, and decreased symptoms. So what you're actually doing is making patients not just symptomatically better, but physiologically better.
Yeah, I think that that's true, and Jim can probably talk about it better than I, but we think of COPD as a disease of obstruction, of getting problems getting air out. But increasingly, as the disease progresses, it's actually a problem with getting air in as well. Matter of fact, one of the things that we sometimes do is ask people to take a big, deep breath in and then take another breath. And that's really uncomfortable, and that's where the COPD world tends to live.
But if you tonically dilate the bronchioles with some of these long-acting agents, then you help the lung empty?
Yes, so one of the most important pathophysiologic processes that leads to dyspnea, shortness of breath, is the air trapping, as Byron just points out. So our goal through lung volume reduction surgery, bronchoscopic lung, all those things are to reduce that volume of air in the chest so that maybe some good lung could inflate and be better for you.
But I mean, the tonic volume goes down as long as you can keep the resistance and the caliber
Right, exactly.
better.
Keep the caliber better than the volume of air in the, in the chest. And a lot of that's dead space and ineffective, poorly
Got it.
ventilated lung.
And I don't want to leave this discussion without talking about escalation, de-escalation strategies here, because you've got to be riding this tide, right?
Yeah, so you know, one of the interesting things, and you guys I'm sure have seen this, as Byron says, we've had a lot of drugs, and now we have more drugs with different durations of action mechanisms that can combine, that have different devices. Steroids have a role, not as broad as they were before, and so one of the concepts that I think all of us have wrestled with in this field is how we provide guidance to a primary care clinician who, as you said, Peter, has got 15 diseases they got to deal with, and they got 8 minutes at best to do this. With the concepts of how you can consider adding and withdrawing therapies for individual patients. And I think what you're going to notice over the course, and it's already happening over the last 2 years, over the course of the next 4 or 5 years, there are going to be increasing approaches to provide primary care clinicians, they're the ones that are dealing with a bulk of this, relatively simple approaches on when you add, what you add, and when you subtract particular components, in part because they're used to doing this already. They do this for multiple disorders, whether it's hypertension, coronary disease, diabetes. We're actually learning from them. Oh, this is a good idea.
And that's been the asthma approach for a long time. I mean, this whole escalation, de-escalation, that's what asthmatic therapy has been for a long time.
But there's an important difference between COPD and asthma. In asthma, the ICS is the predominant component, and beta agonists follow if you don't resolve symptoms. In COPD, bronchodilators are key. These folks are never completely reversible, and inhaled corticosteroids are adjustable based on the individual's attributes. It's the opposite, and that's critical because you can't just use an obstructive airways model across asthma and COPD. They're different.